So I'm going to talk about what the vascular pathology looks like in Dego's disease. And in order to do that, I wanted just to come back a little bit and discuss the structure of arteries, because at least in the non-cutaneous components of it, I'll talk about the dermatopathology of it later, but in the non-cutaneous components of Dego's disease, there's a very distinctive type of vascular pathology that we see. The histopathology in the skin is really much more ambiguous, and it's really the combination of one of a type of findings in the skin combined with the appearance as seen by the dermatologist from the outside, not under the microscope, that allows the diagnosis to be made. So if we come back and think about arteries, so these are the vascular channels that run from the outflow tracts in the heart, from the aorta, large muscular arteries that supply the organs, branch eventually to arterioles, and then give rise to the capillary bed, where the vascular to tissue exchange of oxygen and metabolites takes place. These vessels have basically three layers to them, a layer known as the intima, the media, and the adventitia. And it's important to know the differences in order to understand distinct types of pathology, because different disease processes target different areas. And as I said, so there are distinct predilections in different compartments. The intima, if we start by just looking at my simple bullseye schematic, the intima is the region that sits, so here's the lumen where the blood would be. This red line is the endothelial cell layer. It is a single layer, highly specialized. It is a non-procoagulant surface normally, so the blood is not initiated to begin to undergo the coagulation cascade. So it is normally non-thrombogenic, although when activated by the immune system can become thrombogenic. It sits on a relatively thin layer, which is the intima, and the intima is separated from the media in muscular arteries and arterioles by a layer of elastic fibers known as the elastic lamina. In larger arteries, it is even thicker in multiple layers, but in most of the arteries that are affected in Dego's disease, it is a single layer of elastic lamina. The media, which consists of vascular smooth muscle cells, which are arranged circumferentially so that if the blood is flowing down the pipe this way, the smooth muscle cells are oriented spiraling around it and give it its strength and allow for its responsiveness to changes in pressure and allow for regulation of blood supply. And then out past the smooth muscle layer, one has the adventitia, which is really only seen in large muscular arteries and arterioles. And once one ends up with tissue-penetrating vessels, there really isn't an adventitia. If we actually look at an example here, seeing this is a leptomeningeal vessel, one of the types of vessels that's commonly involved in Dego's disease, in visceral forms of it, and leads to cerebral infarcts. One can see these cells that are oriented this way, these little pink bits here. Those are the smooth muscle cells. The elastic lamina is sitting right below, between it, and here is the endothelial layer, and really no visible other intimal tissue apart from the endothelium. This is the lumen, and then out here is the adventitia. This is the surface of the brain here, and these are the arachnoid membrane sitting right there. So that's what a normal vessel looks like. In order to talk about vascular changes, I just want to remind people, what happens, what is the function of the vessel and what can happen to it. It is basically a pipe designed to deliver blood. Okay? If one decreases its lumen, okay, you've basically got a clog in that pipe, and you are unable or incapable of delivering the appropriate amount of blood for a fixed amount of perfusion pressure. Basically, the amount of blood combination of blood pressure and cardiac rate. So that luminal narrowing can result in reduced perfusion of organs, which can lead to ischemia, decreased supply of oxygen, decreased clearance of byproducts and the like, and lead to injury. You can also end up with propensity for thrombosis. And we have to go back and remember the basic three ways that you can promote thrombosis in a vessel. Okay? One is to change the flow pattern. So if you slow flow down and have stasis, that is prothrombogenic. Blood is more likely to clot. If one changes the substrate, so either by rupturing the endothelium, transecting it, and exposing any of the subendothelial tissues, the collagen matrix, the basement membrane material of subcutaneous tissue, or if just one cuts oneself, all of the subcutaneous tissue that's exposed is prothrombogenic, and so one begins to form a blood clot when blood is exposed. And the third is an altered propensity of blood to clot, as one sees in clotting disorders associated, such as the hemophilias, or even the milder ones associated with mutations in some of the clotting cascade components, like Leiden factor V, which is a relatively common genetic polymorphism that leads to a slight predisposition to clotting and is associated with an increased risk of things such as deep venous thrombosis in people with long airplane flights and the like. It puts people at risk for that. What I'm going to try and show you is that in Dego's disease, both there is probably some stasis and altered flow patterns associated with luminal compromise, and probably also an altered substrate type interaction between the vessel wall and the blood that leads to the propensity to have clotting and ischemia associated with that, as well as just the occlusion of the vessel by lumen. There's really very little to suggest that there is any intrinsic clotting abnormalities in patients with Dego's disease. So before I talk about that, I want to just show you sort of the more classic examples and the sorts of things that we typically see when we look at vascular pathology associated with a distribution of disease, such as one sees with visceral involvement in Dego's disease. The characteristic pattern is to see multiple organs involved with ischemic lesions. So it includes typically brain, GI tract, as well as those are the two major targets. And we see similar lesions in patients with atherosclerosis. The occlusion of vessels is associated with what's a very characteristic change in the vessel wall involving the intima, where there's so-called intimal proliferation. One accumulates lipid, including cholesterol, inflammatory cells, both macrophages and lymphocytes, calcification, stiff calcified vessels, and also proliferation of smooth muscle cells. Separately, one can get vasculitis, which is a true direct inflammation of the vessel wall. That activation of the immune system in the context of a vessel activates the endothelium, leading it to express the adhesion molecules that are involved in interaction with white cells and platelets in the circulation, increasing their adhesion, secreting prothrombogenic substrates on the surface of the endothelium, and leading to localized coagulation. If we look here at a cerebral vessel, again, this is a very characteristic lesion of atherosclerosis. It is an asymmetric lesion. One can actually see the elastic lamina quite nicely here, the smooth muscle out there, and eccentrically located proliferation within the intima. So all of this is closer to the lumen than the elastic lamina, so it is by definition intima. It has spaces which had calcification and cholesterol. It's got areas with macrophages and lipids. It's got smooth muscle cells in here that have grown in from the muscularis layer of the media. This is the classic occlusive lesion of atherosclerosis, which is sort of the typical type lesion that we think of as causing ischemic lesions in multiple organs. Dego's disease can be distinguished on a variety of bases. It's non-inflammatory. There aren't lymphocytes there. There aren't macrophages there. So it is a non-inflammatory lesion. It's characterized by having an intact elastic lamina, and typically in the inflammatory lesions, granulomatous vasculitides, giant cell arteritis, as well as others, one ends up with damage to the internal elastic lamina. The lesion is really quite restricted to the intimal layer, as I'll show you in a moment, and it is a proliferative lesion. There are too many cells making up the intima and decreasing the cross-sectional area of that of the vessel, but they are not inflammatory, nor are they smooth muscle cells. So in that sense, it is completely distinguishable from the classic atherosclerotic lesion, and in fact, the inflammatorily or immune-driven lesion that we see in transplanted hearts. So that in a cardiac transplant patient, the endothelium, the vasculature of the heart, is a graft. And there is a graft-associated atherosclerotic lesion, which looks different than classical atherosclerosis because that graft is not immunologically identical to the rest of the body. Those lesions are concentric. They are not anywhere near as macrophage-rich. They look much more bland and cellular, but they are very distinct because they do contain smooth muscle cells within them. And unlike that, the lesions in Dego's disease do not contain smooth muscle cells. This is an example of a lesion in a case of Dego's, and I've had the chance. There are 3 cases that have been diagnosed with Dego's disease at Mass General, and I have rendered a diagnosis in one of them, but I've had the chance to review the other two out of our files. They go back to the early 1960s. So here in this vessel, one can see the smooth muscle cells running around. They're concentric as they should be. The elastic lamina is right here. It's slightly refractile. It's slightly pinker than the smooth muscle around it, and it's a little wavy. I hope you can see that. And then internal to it, there are far too many cells. We don't have the nice layer of smooth endothelium just tacked down right above that elastic lamina. By staining, there are no inflammatory cells in here. If we come to a slightly higher power, maybe here you can now get a better look at the elastic lamina there. You can see this collection of cells. They're not smooth muscle cells. They're not macrophages. They're not inflammatory cells. And one can actually even see a little bit of thrombus of blood clots sticking to the surface of it, suggesting that this has been compromised either by occlusion, partial occlusion. The cross-sectional area here is about 20% of what it should be. So the flow will be markedly decreased. Decreased flow associated with stasis is prothrombogenic, or that the cells on the surface that have come up past the endothelium are procoagulant. Just to stain, this is a stain done for the elastic fibers, showing you where that elastic lamina is, and here's all of that cellular components that are within it. And now here on a trichrome showing you, you can see the pinkness of the smooth muscle cells, and most of what's in here does not have the appropriate staining to be vascular smooth muscle. Another case here in a smaller caliber vessel, you can see here's the elastic lamina. This is a similar vessel to that one normal one that I showed you. This is right at the edge surface of the brain right here. This is all of the proliferative lesion. This has clearly thrombosed and been recanalized. So when one has thrombosis, one can get recanalization. You can see that the red blood cells are running through several separate channels in here. It's the typical pattern of a vessel that thrombosed and then reopened. And that's why one can get hemorrhagic infarcts associated with this as they thrombose, and then the thrombus begins to break up, leading to hemorrhage. Another similar vessel from a different case. Again, the elastic lamina is out here. Here is the proliferative lesion. In the center here, there was a lumen, and this portion that's right in here, internal to those collections of red cells, is also a thrombus. It's a fibrin thrombus sitting on top of it, suggesting that this has been a procoagulant predisposition here. Here on the elastic stain, one can see all of the cellularity. In this example, completely obliterating the lumen, again, without any inflammatory component to it. So to sort of lay out the various parts, these are the typical appearance with the proliferative lesion and thrombus, all of that occurring internal to the elastic lamina. It's a pure intimal lesion, very distinct from most of the other vascular processes. The consequences of these are basically inadequate blood supply to the target organ. In the brain, it leads to infarcts, which are clinically recognized as strokes. They can have any anatomic distribution. They really follow whatever vessels are involved. They can be small vessels. They can involve large parts of the brain, small parts of the brain, and the like. Because they cause infarction, and that leads to associated edema, one can actually get a feed-forward process where increasing edema is associated with decreased ability to perfuse the brain, especially given compromised vasculature, and sort of accelerating additional propagating infarcts. The dermatopathology of Dego's disease is far less specific than the visceral arterial pathology of it. It doesn't have this same lesion at all, and it has histologically an overlap with a bunch of other diseases. And I think that much of the literature based on it is based on the dermatopathology, saying, I can't tell the difference from this biopsy from a biopsy of the other process. Maybe that reflects that these are convergent mechanisms, rather than saying, I can't tell them apart when I look at the patient's rash. And actually, some of the examples that I'm going to show you were actually provided to me by Bernie Ackerman. So I actually have some slides from him, because these are even harder to come by than the vascular lesions. There's usually a little bit of a lymphoid infiltrate. They can get telangiectasias, sort of small proliferations of vessels that associate with the hyperemic rim. There is a mucinosis. They end up with deposits of myxoid extracellular matrix material in the upper part of the dermis. And as I'll show you, the boundary between the dermis and the epidermis is very smudged. It is not histologically as crisp as it should be. And the epidermis, the top layer of the skin, thins out. So it is not as thick as it should be for the anatomic site, but it is also slightly hyperkeratotic, which is usually a process that's associated with thickening rather than just with thinning. Here on this biopsy, one can see a little bit of, so this is the surface of the skin here. These are the vessels. This is the epidermis down into the dermis. These are the dermal vessels. There is a small amount of lymphocytic infiltrate around some of these vessels, not overly pronounced. And here in the same biopsy, stained with Alcian blue, which is a mechanism to stain for neutral to basic mucopolysaccharides, one can see the blue deposition of material in here, which represents the mucinosis in the upper layers of the dermis. Another biopsy, again, showing this moderate hyperkeratosis here with the external keratin layer out here with a relatively thin dermis. Again, a little bit of lymphocytic infiltration around some of these. This is the hyperemic rim out here, whereas this is the bland white center with decreased vasculature apparently within it. A few scattered lymphocytes around some of the vessels out here, relatively small and minimal. Also note, none of the lesions here, we're not at a site where one has the larger muscular arteries that one could even find, in which one would expect to find the vascular lesions of Degas disease. Here, there's this very strange, the color isn't coming quite across quite right on the screen here, but this is the epidermis, the basal layer here, and the dermis, and there's this very funny distortion and change in appearance right at the junction. It is blurred and smudged. It should be much crisper. You should have material that looks like this coming right up down to the interface, right up to the interface here, and it's a very striking blurring. Maybe seen a little better here. It's often referred to in the books as smudging or blurring of the boundary zone right in here. So, sort of final comments. I think the predominant vascular lesion, and particularly the lesion that is associated with the significant morbidity and mortality of the disease, is really the large arterial lesion. It's a non-inflammatory, non-destructive. The vessels remain intact, but it is an intimal lesion that leads to occlusion and prior to occlusion, compromise of vasculature. It is histologically quite distinguishable from the vasculitides, from atherosclerosis, and from any of the infectious vascular processes such as zoster vasculitis. So that histologically, these the vascular lesions here, are relatively distinct from all others. So we'll stop there. Ellen, whether there are the telangiectatic changes in brain. From the two autopsy cases that I've looked at, there were not significant telangiectatic changes. There were clearly infarcts and then reactive hyperemic vasculature around infarcts. But you see that in infarcts from atherembolic disease or any process. So I don't think that there was anything distinctive that would line up with that sort of hyperemic rim. And that hyperemic rim in the bowel may be a similar sort of, distorted perfusion patterns in the setting of ischemic changes.
I wonder if I could invite Noah and Bonnie to come up to the front, and we're going to take some questions now. Maybe I could start by asking, what do you think those cells are that are crowding into the lumen of these vessels?
So I think it's not clear at all. I mean, they don't really, they don't mark like smooth muscle cells, and they don't really mark like endothelial cells. Endothelial cells usually, are flat oriented, and you don't get them growing as a discrete solid mass like this. I think it's a question of determining what a cell type is really requires having specific markers. And if it's not something that's in one of the normal categories, then it becomes very difficult to try and give it to assign it to a category, because it's not something that's a normal piece. And we use our markers to define things as based on what they are as normal.
Yeah, I mean, the other way to go about looking at it would be by some kind of gene expression. Although, I mean, then you would need to have cells to somehow kind of gather something from. But I mean, even then.
Yeah, I mean, at the time of the case here, the most recent case, we actually discussed whether we could try to use a methodology that we have in our lab to dissect out those individual cells and separate them from the rest of the vasculature. We can work with as few as a few hundred cells, but even in that, we didn't have anywhere near enough tissue to try and begin to address that sort of issue.
Please come in. So I think our speakers all did a good job of balancing between the two audiences that we have, which is that we have a lay audience and we have a medical audience. And I'm sure that there are a lot of questions on both sides of the divide, but maybe we could start out with Constantine. Do you have a question?
My question is, do you think that you can put the diagnosis if you see only a histological sample from the brain? Or do you need skin lesions?
Well, so that's...
So the question was...
The question was, in case of systemic involvement, does the histology of the internal organ, for instance the brain or the intestine, is enough to put the diagnosis of the disease? Or do we, in any case, need the skin lesions? So it means that is the histology alone enough to put the diagnosis, or do we need the clinic?
So is this pathology sufficiently unique to Dego's disease that that by itself can give us the diagnosis?
Well, in the most recent case that we diagnosed here, we had the biopsy. We recognized that there was something abnormal about it. And with Dr. Cavanis, who's going to speak later, he and I sat at the microscope, and he actually suggested that it could be Dego's at that point, except that the clinical context was completely wrong. We had none of the skin lesions at that point. We didn't have any visceral lesions. And in fact, the CNS lesions that were associated with it were not infarcts. And so while we had the lesion and all of the histology suggested that's what it should be, there was no clinical context. And it was only subsequently, as other lesions came up, that the pieces came together to allow the diagnosis. I think it depends on whether you have, if you have the clinical findings in some way, as well as the histology, that's different than having a divergent set of clinical findings and the histology. I think in the face of a divergent set of findings, it's very hard to make the diagnosis only on the histology. But assuming that there's an indication for the biopsy that is somewhere along the Dago side, then I think the histology is adequate to do it. That's different than the dermatopathology. The dermatopathology will never be signed out as Dago's disease. Okay? The dermatopathologist will say, describe it and say, in the context of the cutaneous lesion you've described, this is consistent with Dago's disease.
Yeah, I mean, just when you say it, it reminds me of Jeff Gottlieb, who who works with Bernie. Whenever you show him a hard case, he always then goes through a Talmudic thing and says, "Oh, you're trying to fool me into just saying it's Dago's, but it could be lupus or something else." It's like when you show him a pyeloventricular carcinoma, you say, "Oh, you're trying to put me into a corner and say it's not just an exuberant pyeloventricular, it's definitely this." So I would say that in my thinking that Dago's can just kind of manifest as a systemic process. Skin involvement would not be a sine qua non. But again, it's rare, so it can be missed. I would tell you that when I see a patient who has purely kind of cutaneous Dago's disease, as sometimes I'm referred patients, the first thing that I do actually is to guaiac their stool. Because I would like to see, because that to me would be evidence of systemic involvement. But I think that based on my review of all the papers, having a systemic Dago's and starting kind of systemically is wholly within the range of the spectrum of what we know. And maybe, but in terms of the pathological thing, I would defer to a pathologist, but it seems as if maybe it can be diagnosed. But it's hard because we have so few cases that it's hard to come up with the patterns.
So in terms of gene expression profile experiments, why haven't those been done? You made a reference to the fact that it's tough to get enough tissue to do those things, but what about
not clearing skin samples that you have anything that is a specific lesion. I mean, in the vascular lesions are clearly distinct, and one could go and collect those cells that are in the intima. The problem is that most of the time you get a small biopsy, if any, and it's very hard to come by enough tissue in order to make that comparison. And you have to know what to compare them to. In the skin, what would you sample? You could take the entire punch biopsy, but that's going to give you an enormous number of mostly irrelevant and extraneous elements.
That's true, but you could use antibody purification methods to isolate epithelial cells from a skin biopsy sample.
Yeah, except in the skin, there's no evidence there's nothing to suggest that the endothelium is the relevant target.
I mean, that the problem is we just don't know what we're looking for, and just from a basic kind of principle of like the elephant, if you don't know what you're looking for, but you can't find it, and we just don't even know what we're looking for. I mean, that we see a lot of stuff. We list a lot of stuff, but then why is it the way it is? There's no theory to even approach that. So what are you looking for? I don't know.
Let me restate the question, if I may, which was that there's a technique that's available that allows you to look at which genes are being expressed of the 22,000 gene complement that every human has, that theoretically there could be a pattern that would be specific to this disease that might separate it from others, if I'm interpreting what you're saying correctly.
Well, it's even more complicated. As was just pointed out, what are we looking for? I mean, like, is anything actually pathologic kind of going on in the skin? Or is the pathology kind of elsewhere and just manifesting in the skin? I mean, there are any number, of processes. I mean, like my favorite one is PXE. Do you know what gene causes pseudoxanthoma elasticum? It's some gene that's mostly expressed in the kidney and in the liver, not really in the skin. Yet the skin gets lesions. I don't understand that either. That's one more thing I don't understand.
I'm not aware of any papers that have been published that anybody's looked at this question, but I'm sure there's this whole new burgeoning literature on gene expression in different conditions. There are a variety of other techniques available too, like the Kaposi sarcoma virus is such a good example of discovery of something that nobody expected, because this group at Columbia used a subtractive hybridization technique where basically they took all the DNA in an affected lesion and then extracted DNA from neighboring skin, and then they subtracted out all the stuff that was from the normal skin, and what they were left with was one little 300 base pair sequence, and they used it as a handle to pull out this huge virus that's like the Epstein-Barr virus that causes mononucleosis. Did you have any other thoughts? Okay.
But that's why that things are going to come from where we don't expect them. And maybe somebody like you will find a technique and find it. I mean, it will happen.
One thing that has puzzled me, looking at the pathology, is that the body has this astounding system for providing blood supply to tissues that are deprived of their blood supply. So, for instance, when the heart has its circulation compromised, there's a whole system that comes into play that detects the low oxygen concentration, produces factors that mobilize new blood vessel formation, and then you get this neoangiogenesis to provide blood supply to parts of the heart muscle that are otherwise starved. And it seems like in this condition, like when you were showing the skin pathology, you have these areas in the dermis, or below the dermis, that are lacking in blood vessels. And despite the fact that there's obvious necrosis going on, there's clear deprivation of the blood supply, the new vessels seem to be missing. I mean, could that be part of this puzzle?
The time course of growth of vessels is somewhat complicated in terms of what the stimuli are. There are different growth factors. I don't know that there's good growth factor generation for the vascular endothelial growth factor that's involved in sprouting and development of new vessels coming out of in the skin. It clearly is made in myocardium and made in some other tissues. It's made in brain, and one gets neovascularization in tumors. But I don't know that there's a good source of it in skin, whether the epidermis ever makes enough to generate more vasculature.
We wrestled with this problem with this patient that we saw 3 years ago, because on the one hand, you have this endoproliferative lesion in the blood vessels, and so at one level you would think it would be productive to stop the proliferation of new tissues. But on the other hand, to the extent that the tissues were hypoxic, lacking in sufficient oxygen, by blocking new tissue formation, you potentially block the ability to form new blood vessels that could supply the blood to those areas.
I can make a remark on this point. Maybe normally you would expect if you have a vasculitis with a blood vessel occlusion that a so-called neo-angiogenesis would take place. But the problem is maybe there's something that is inhibiting VEGF, for instance, to be secreted, and that's why we don't have the production of new vessels, because we think there's a new category of drugs, anti-VEGF drugs like Avastin, for instance, and if you read the complications of these drugs,
Hemorrhage.
Microvasculitis is in some cases produced. That's also
Well, yesterday there was a speaker at the American College of Rheumatology, Judah Folkman, who many people may be familiar with. But he's a surgeon at Children's Hospital, but he's made his whole career studying blood vessel formation in cancer and how certain tumors mobilize the body's own ability to grow new blood vessels in order to satisfy the nutritional needs of the tumor. And it's interesting that in rheumatoid arthritis, for instance, there are huge amounts of neoangiogenesis, or the formation of these new blood vessels, within the part of the joint that's diseased. So these kinds of inhibitors, like Avastin that Dr. Theodoridis is referring to, have these potential broad applications because you could potentially block the formation of blood vessels in cancer or in arthritis. And in a sense, we might think of this as the opposite problem. How could we promote the formation of new blood vessels that would satisfy the nutritional needs of these tissues? Is
Well,
that?
But I thought, a medication that we use sometimes is Regranex or platelet derived growth factor, which is good to kind of heal things up because it lays down kind of more skin and vessels. I don't know, but again, it's that the role of growth factors is clearly something which needs to be better understood in this and angiogenesis.